2021 to everyone. I think we have had a very excellent talk from Prof. Chan that shows the importance of oxygen delivery during fetal life as well as during the neonatal resuscitation. So let's move on to our next speaker. Dr. Subhashini Jayanath is our consultant pediatrician and also the developmental pediatrician, one of the rare breeds in pediatrics in Malaysia. So Dr. Subhashini will be talking to us today on the early signs of autism spectrum disorder. In UMMC, the developmental pediatric has been running quite smoothly from the year before 2015 itself, but from year 2015 it has developed a lot when Dr. Subhashini came back from her fellowship training. And now we do have some fellows under training, as Dr. Subhashini is already a trainer for the developmental pediatrics. Dr. Shobha had also authored a book, which is the Autism in Short, a handbook for parents. So today, Dr. Shobha will talk to us on the early signs of autism spectrum disorder. So the floor is yours, Dr. Shobha.
Thank you very much, Prof. Yazid, for the kind introduction. Good morning, everyone, and Happy New Year. Let me just share my slides. I think I've got it here. Okay. Okay, can everyone see the slides? Yep. I think I'll start. Okay.
Yes.
Yeah. Okay, thanks. So the topic today is early signs of autism spectrum disorder, or autism. And I've divided it into two parts. So the initial part is just the overview, which is very brief to give a bit of context to everyone. And then the second part, which I'll focus on a little bit more, is the early signs or the red flags of autism. Overall, if you look at the overview, it's basically just a different way of looking at the world. And when you think of neurotypical people as well as people with ASD or autism, it can be argued that they're developmental differences rather than a pathology per se. This is the way that it's viewed for a lot of developmental differences as well. But if you look at the definition of autism, the core things are that it is a neurodevelopmental condition, but it affects things like social functioning, communication, as well as the patterns of interest and behavior. So it does affect different aspects of not just social functioning and communication, but also things that people do repetitively. And the important take-home message, I think, is that it is a lifelong condition. So getting a cure to autism or a complete resolution of autism is less likely, and that's something that we need to mention when we counsel. So the mainstay for diagnosis is either the DSM-5 or the ICD-10. The only thing I want to mention here is that with the DSM-5, it's a little bit more inclusive than the previous DSM-4 text revised. And all these conditions here, autism, Asperger's, childhood disintegrative disorder, and PDD-NOS, which is pervasive developmental disorder, not otherwise specified, all come under autism. And I think that's important because can you imagine giving a parent a diagnosis of PDD-NOS for a child? It can be very alienating and very unusual to say something like that. Whereas now when we say autism, it seems to be, it's a more comprehensive diagnosis. And the other thing is that it's a better way of picking up younger children. So for diagnosis, we need to have functional impairment, because if there's no functional impairment, then there's no pathology. And it shouldn't be solely due to developmental delay, because a lot of other conditions can also mimic autism. For example, a child with very severe intellectual disability can sometimes have autistic traits and features, but not clearly speaking be autistic. The features should be present early in childhood, but it's also important to remember that they do not always manifest very early. They're there, but they are sometimes more apparent only later on. Okay, so there are two core domains, which are the A features, social communication and interaction, and the B features, which are behavior, interests, and activities. In order to have a diagnosis of autism, you must fulfill all three A features and at least 2 out of 4 of the B features. For some people, they fulfill all 4, some fulfill 3, some fulfill 2 of the B features. But if they do not fulfill at least 2, then we have to reconsider and see whether this is really autism or not, or whether it's another developmental condition, say, such as social communication disorder. Okay, so this is just to give you an example of the A features and the B features. I won't go into great detail here, but if you look at the A features, these have to do with interaction and communication, not necessarily language, but non-verbal communication as well. And often when we consider a child with a diagnosis of autism, we will try and take off, put aside the language portion and put that in a packet on its own and look at the non-verbal communication. So things like gestures, posture, facial expression come in. And reciprocity, it's the two-way interaction. So like, for example, now, because this is a webinar format, I'm not getting any reciprocity from the audience, but I hope that if there are things that you want me to clarify, you will let me know. And that's an important part of social interaction, because a lot of communication actually is non-verbal. There's a lot of problems as well with developing relationships at the social level as well as occupational level. And that's why play is important. So I'll go a little bit more into play after this. With behaviors, it's the rigidity and the stereotypical kind of behaviors that are done again and again. So not strictly speaking just an unusual behavior, but the fact that the child does it repetitively and does it for no apparent reason, that is a red flag. Also being rigid about a lot of things. And many people can be very rigid about lots of different things. And that's something to remember as well. So we shouldn't take it completely out of context. If someone is rigid, it doesn't automatically mean they're autistic. They need to fulfill all these criteria. And restricted patterns of interest are also important, because it means that they don't have a wide variety of interests. But I think I don't want to give you the impression that everyone who's autistic has only narrow interests. This is just one of the possible features that they can have. All the interests are very intense and hyper-focused. The other aspect is interest in sensory aspects of the environment. And when we say interest here, it means that being overly aware. So for example, maybe being overly aware of certain sounds, certain colors, certain frequencies, lights, that kind of thing. And that's something which you can see in someone who's autistic, but also there are people who have sensory sensitivities as well. And you can often be hypersensitive for certain things, but hyposensitive for other things. And that's something that we also see with, say, feeding problems. Some children have sensory aversion to certain foods and textures, but they're quite happy to put non-food objects into their mouths. So it's not mutually exclusive as well. Sorry, it's just jumped. Okay, so now we'll go on to part 2, which is the early signs. With the main signs that you can see, children can present in many different ways. And one of the ways is that parents sometimes say that they have difficulty talking. So they're not talking when other children of the same age have started talking, or they start talking late. Sometimes parents and carers say that they don't seem to be listening and they're worried about hearing. So making sure that a child who's autistic or a child who has features of autism has no hearing issues is very important, because if we don't consider that and we don't rule out hearing issues, then sometimes we can miss someone with significant hearing impairment and label them as autistic, which is wrong. Of course, we do have a few children under follow-up who have autism and also have hearing impairment, unfortunately, but it is important if the child doesn't have any clear speech to assess that. For children who do not like interacting with other kids, sometimes this is not very apparent, because if you ask a carer or parent, does your child play? Many of them will say, yes, they play with other children. But we need to know the quality of the interaction and the quality of the play as well. And hyperactivity. So the other thing that can be confused with autism is ADHD, which is attention deficit hyperactivity disorder. And sometimes children who have autism can present with hyperactivity, and that can be the main presenting feature. But we have to also stand back and consider, is the hyperactivity part and parcel of the autism, because it is one of the features that can be present, or whether it is a separate thing on its own, or does the child not have any autistic features at all and then only has ADHD. So there are many ways of presenting as well. With some of the very early signs, we should look at a few things. So if you look at this acronym, it's one of the acronyms that's used for one of the checklists, but I've borrowed it here just as a short form because I think it's an easy way of remembering. One is the communication part, which is, as I mentioned earlier, both non-verbal as well as verbal. Attention, which fits in with the ADHD-like features which are sometimes there. Reciprocity, that's a two-way quality of interaction, as well as social interest. So social interest and social motivation are key. Someone who is not interested in interacting with other people will usually, show early signs of that when they're younger, but it may not be very apparent when they're toddlers. It's usually more apparent when they're 2.5, when typically developing children interact a little bit more. So that's why the features of autism usually are more apparent after age 2. And often the diagnostic label itself is fairly stable by 2 to 3 years of age. So I'm going to just mention briefly this section as well. When they did a study on toddlers, 37 toddlers with autism, as well as 22 with developmental delay and 51 who were typically developing, what the researchers found is that the total visual fixation time for the toddlers with autism was actually more on the geometric patterns rather than the social images. And I'll show you an example of that after this. Younger children who had autism tended to focus on the patterns rather than on the people. And this is an example. So they had moving frames here. For most of us, the first time, when you look at this, you immediately look at the children, I hope. And that's the thing that we fixate on. Of course, we will notice the geometric patterns, but with the moving children and the faces, that's far more interesting from a social context for all of us. But for the children who were autistic, they tended to find these more fascinating than the people. And that was a very telling early sign. And now there's also increasing research in that area as a biomarker, early biomarker for ASD. And there's studies coming up with visual tracking as well. Okay. In terms of social interaction, response to name is a big one. Most children, if they have intact hearing, will respond to their name. And if they don't do that, then we should consider the reason for that, whether it is that they have difficulty hearing or is it that they're just not responding to calls. Gaze tracking is the ability to follow and look at something that someone else has pointed to. So if you point and you say, okay, look at the bird, the child should be able to look and visually fixate at the point that you have pointed. If they're searching for it constantly or they can't seem to visually track, that's one of the features that we see as well. But of course, you have to exclude visual impairment before you can say that it's poor gaze tracking. Joint attention is the ability to focus on a common thing and to sustain that attention. So it doesn't mean that, if say for the example, the child points out something or brings something and shows that, but then they continue to talk about it and someone else is not really paying attention to it, then that person has issues with joint attention. Conversely, if you are showing a child something, say in a book or a picture, and you're trying to show the child what it is that you're sharing with them, and they have difficulty sustaining that attention and the mind wanders, then that's an issue with joint attention as well. And these are very subtle but very important aspects of social interaction. Varied expressions are also important, and you shouldn't consider things like, say, excessive mimicking, gesturing without context. Those don't really count. They have to be responsive expressions. Sharing interest is bringing something or showing someone just for the sake of enjoyment. If a child brings, say, a can or a bottle and asks someone to open it for them, that's not sharing interest. That is reaching out and getting someone to do something, but that's merely to meet their needs. So that does not qualify as sharing interest. With communication, richness of gestures and not just the presence, yes or no of gestures is important, and coordination of nonverbal communication. So are these gestures in context or are they just merely pointing things out on their own without having that quality of interaction as well? With prosody, we're talking about language and speech in particular, that variation in tone and pitch, as well as the rhythm. So sometimes people who have ASD also have issues with monotony. Like, for example, they may speak, but they don't vary the intonation. These are generalizations, of course, and it's important to remember that not everybody will have these features. With repetitive behavior and interest, movements with objects, for example, spinning a pen, spinning the tires of a toy car, all of those are repetitive, as well as repetitive posturing. So unusual postures, hand regard, looking at their fingers, doing things repetitively again is the key. I'm repeating that because I think it's important to emphasize that it is repetitive. And if it's not repetitive, it may not be pathological. So with 6 months to 1 year, I'm only going to pick up the most important aspects, I think, at this age. Babbling can sometimes present later. So if a child is not babbling at 6 months, that's still considered normal. But if by 10 months to a year, you're not hearing any sort of babbling, that would be unusual. And gesturing again, as I mentioned, and eye contact. With eye contact, the easiest way of remembering it is that it's either normal or good eye contact or unusual eye contact. So it's either a yes or no. It's difficult to say slightly unusual eye contact, quite good eye contact. You need to sort of commit at a certain point. Is the eye contact normal or is it abnormal? And that's an easier way of differentiating. Some of these other things I mentioned, but imitation is another thing that's very important. If you look at a typical toddler or young child, a young infant or child, they tend to imitate from very early on. And this is even seen in babies. When you smile and you look at them and you have different expressions, they tend to mimic those expressions or try to mimic your sounds that you're making. And reduced attempts at this are considered reduced imitation. Also, imitation of everyday activities is important, but it's not just imitating simple actions. The rest, I think I've mentioned already. Absence of any meaningful words. So by this age, they should have at least one meaningful word. And it doesn't matter if the pronunciation is unclear, because we know young children tend not to pronounce words very clearly. But if they use a word specifically with meaning, even if it doesn't sound exactly like the way it should be pronounced, it still counts as a meaningful word, because here we're looking at the content of language rather than the articulation. Whereas there are children who have a lot of words and they name a lot of objects, they say a lot of things, but there's no meaning behind that. And that doesn't quite qualify as having meaningful usage of words. Excuse me. So some of the things overlap with the previous slide, but the additional thing is that if you look at the cognitive domain, by this age, they should have some exploratory play. And exploratory play is basically play where they, for example, they open drawers, look inside, they have cause and effect toys, they press a button, something happens, or they explore things in their environment. This is a very important cognitive milestone. It may be difficult to manage, and sometimes parents find that very difficult because they put things out and children are into everything, but it's actually a very important stage of play, and play is actually very serious business. With fine motor and vision, unusual visual attention tends to surface at this point, and that is where they find certain things very fascinating. So like flickering lights or moving things, spinning objects, the washing machine when it's on. And it's also very important to emphasize at this point that children at this age tend to find these things interesting, and that's still normal. It's only if they spend an abnormal amount of time doing that, or if they find, they sort of notice these things which other people don't notice, and they spend time observing them. Okay. Also, if you look at 18 months, the absence of meaningful words at this point is very, very unusual. They should have at least 2 to 3 meaningful words, not necessarily in phrases, but at least single words with meaning. And the ability to obey simple commands is important. A simple command is like a one-step command where you say, bring the ball here, or lift your hand, put up your hand, sit down. So those sorts of basic commands, they should be able to master at least by 18 months. Disinterest signifies the social motivation. Are they motivated and interested in other people? And the other points I've already gone through, but relational play is basically using an object for its intended use when you're playing. And at 18 months, it's also very important to look at these things like showing affection and are they okay with hugs? Are they okay with affection from other people? Very young children are also responsive to this, but ordinarily at 18 months, they themselves will come and seek this kind of contact. Okay, so at 2 years, if they have no words with meaning or only single words, again, we get more and more concerned at this point. And the use of jargon. Jargon is basically non-words which they just use repetitively again. Neologisms are new words, so new and logism word, and these are made up words which make sense to them but not to other people. Sometimes parents come and they say that they have their own language, or they'll say it's the alien language, and we know that's definitely what they mean when they are referring to jargon and neologisms. Echolalia can be immediate or delayed, and that is when they repeat things that you've said. So if you say something and the child mimics that and repeats it, that's considered echolalia. Delayed echolalia is where they repeat, like say, topics or things that they've heard, dialogue or that they've heard before, and that's something that's done later on. The importance about echolalia is that in this context, when we talk about it, it means it's used without meaning, without context. And that's a crucial point as well, because many children will repeat dialogue. At the time, I think it was 2014 or 2013 when Frozen came out, all these children were running around singing Frozen, and that was just completely normal. But they were using it in context, or they were recalling things that they had heard. But in this context, echolalia is without meaning. Okay. Being in their own world is again not having interest in other people, and poor response to other people's overtures. It's also telling when we ask, what happens if another child comes to your child and says, can you join in, can you play? Excuse me, does he respond, does he join in? If the parents say no, he's not interested at all, he ignores them, then we know that that's a poor response, because some children are naturally shy and they may not go out and seek other people, but they respond appropriately, and that would still be considered neurotypical. I think the stereotypies are repetitive movements, repetitive behaviors as well, and symbolic play. So I'll go into symbolic play a little bit after this. This is the last one I'm going to talk about in terms of red flags. At 3 years, so stock phrases are phrases that they use again and again to mean many things. Like they may say open when they're asking you to close, when they're asking you to sit down, when they're asking you to get something for them. Just using that same phrase or that same word again and again is a stock word or stock phrase. And not being able to follow at least 2-step commands at this age, at 3 years, is slightly unusual. With children who have language delay, which is not attributed to autism, they can also have this delay. That's why we need to look at the whole context again and see whether there are other issues with social interaction and behavior. Self-care, at this age, most children, if they've been exposed, will be able to do some amount of self-care. But please remember that you need to ask whether they've been taught. Typically, I think in this country, many people don't do toilet training very early on. And it's not so much a reflection of the child's inability to do it, but that they haven't had that exposure. So it's very important to see what they've been exposed to, what they've been taught before we say, yes or no, delayed or not. No concern for others relates to empathy, and this is like feeling sorry for someone else or picking up on other people's emotions, and that has a little bit to do with putting yourself in someone else's position, which is a very, very important cognitive and social step as well. Solitary or parallel play. Okay, I'll go into play. Okay, so now basically, the reason I'm talking about play is because it's a very, very important way of assessing whether children are developing typically or not. And that's why play is one of the rights of children, because they really do learn from play. If you look at relational play or functional play, it's taking something and using it for its use. For example, if they take a mobile phone and they start texting or they start doing things on the phone, that will be considered relational play. But taking the mobile phone and just pressing buttons without actually pretending to do anything and just watching something does not constitute relational play. Representational play would be, say, for example, taking a rectangular block and pretending to type on the phone or talk on the phone. That's taking something to represent or symbolize something else, and that is a higher order play skill. So that's slightly better, or rather it develops later than functional play. These are examples of relational functional play as well as representational play. And imaginative play is a step further again, because they use things which they can relate to, like everyday things, coming to the doctor, being checked, trying to sell things in the shop. But once they get to fantasy play, this is a higher order again, because it means that they're talking or relating to things which they have no real world relation to. And that requires a lot of imagination. So for example, pretending to pick up the phone and calling their imaginary friend, whom they've never ever seen, that constitutes fantasy play. These are just examples again. So solitary play is the main type of play when the child is less than 2 years, and that can be normal. Spectator play is like what this little boy is doing. He's watching his friend do something. He's a spectator, but he's not really actively participating. But he has the social motivation to see what it is his friend is doing. Parallel play is like these two boys where they're doing things separately, but they seem to like being next to each other. And the important thing about parallel play is that you need to see the age as well. So from 2.5 to 3.5, this is the predominant type of play. But for a neurotypical child, they will also have a lot of other types of play in addition to that. If they're only doing parallel play, then you have to consider whether the child has features of autism as well. The other two types are associative play and cooperative play. So with associative play, excuse me, there's no shared goals. They interact a little bit, but they don't have main goals. Something which I think if you consider politicians, that's something that we can consider representative of that. With cooperative play, they're actually cooperating together and working together for a common goal. And that means there's a lot of interaction and there's also a lot of focus and cooperation. So this is a higher play skill as well and typically develops after 4 years of age. Okay, so just briefly, in terms of early signs, there are a few types of checklists that you can use to detect this. And one is the parent or caregiver rated checklist. Another type is a clinician observation. And the third type, which is probably the most robust, is a variant of the clinician administered as well as with input from the parents. But these are screening tools, they're not diagnostic. And an example would be the STAT, which is it's a quick assessment for children, which can be done by the clinician. Also, there's the POEMS, P-O-E-M-S, which is a parent observation scale. But after doing all these things, they still need to have a final assessment. The most famous screening tool is, and one of the oldest, is the MCHAT, the Modified Checklist for Autism in Toddlers. And they have a new revised and follow-up version. So this is what is used in most of the baby books in the Ministry of Health here. And if you go to the MCHAT screen website, you can fill it in for free, but this is in English, and then it generates a score. This is a screener as well. So when it's positive, they still necessitate further evaluation and referral. And we still need to make sure we do a full developmental assessment, but it helps with the pickup rate. These are just the cutoff scores. So 0 to 2 is very low risk. 3 to 7 is moderate risk. And once you get to 8 or more, they need to be referred immediately. The important thing again here is that it's meant for toddlers. So it's applicable and valid for ages 16 to 30 months. But for children younger than 16 months and older than 30 months, some of the questions are not very relevant. Okay, so this is basically just to remember that every child is unique and we really need to consider that when we are assessing them. And it's important to remember that, it's not one size fits all. We need to take a big picture overview. But some of the early signs which I mentioned are important in terms of picking it up slightly earlier. Okay, that's all. Thank you.
Thank you, Dr. Shobha. Thank you for the comprehensive talk on the early signs of autism. I think from your talk, it's very important for us to understand that children needs to play. And when the children play, there's a lot of things or observation that you can do to decide whether this child is following the normal development or just a bit away from that. I think I will just allow one question here. I know a question from Prof. Chan. I do understand that failure of oxygen delivery in fetal life may have a role in the cause of autism. You want to just make a comment on that?
Oh, okay. Thank you for the question. I think when we think of the causes of autism, we know that it's multifactorial. That's the one thing that we're sure of, but there are lots of other things that are difficult to be absolutely certain about in terms of evidence. There is a genetic component, and sometimes we also see families where there are multiple children with ASD. So we know that's something that, and the twin studies also give us that evidence. With early hypoxia, there is also some level of evidence to say that it can impact, but some of it may be attributed to preterm deliveries, other consequences during the antenatal period as well as the time of delivery. So to say that it's directly causal, I personally feel that it's still hard to say, still a little bit contentious, but it is one of the things that we do ask when we ask for antenatal history and the intrapartum history. So we take it into consideration as a possible cause, but I can't say for certain that it definitely does cause ASD.
All right, thank you, Dr. Shobha. I think all of us agree that we had a very good talk this morning, both from Prof. Chan and Dr. Shobha, on two different topics, but very important, very dear to us all as clinicians. I would like to thank all the participants who are here and who are still here listening to those two talks. Thank you very much for your participation, and thank you very much for the two speakers. I will adjourn this conference for today. Thank you.